Okay, I think we can start, and then other people will join soon, I suppose. And so welcome to everybody to the sixth meeting of the Journal Club series organized by Fenice. Fenice is the Italian network for clinical research in emergency medicine. And within this initiative, we invite the authors of the most interesting papers that are published and then that can change the clinical practice even in emergency medicine. And today we have the privilege to have Pierre-François Dequin from the intensive care unit of the Bretonneau Hospital in France. And he's the principal investigator and the first author of a very important, very interesting paper on the use of hydrocortisone in severe community-acquired pneumonia. This is a large-scale randomized clinical trial, which was recently published on the New England Journal of Medicine. And so we are very happy to hear from his own voice the description of the study and the implication for clinical practice and future research. So thank you, Pierre-François, for accepting our invitation. It's a really privilege for us, and the floor is yours. Thanks so much, again.
Thank you very much, grazie mille for this introduction, and thank you very much for the invitation and for giving me the opportunity to discuss with you the results of the CAPCO trial. I am sorry, but sometimes I have some internet connection problem. I hope it will be sufficient to hear me, but don't hesitate to say to me if I have some difficulties with internet. I just have to.
Connection seems good.
Okay. So I will essentially present the methods and results of the CAPCO trial, but I have also some slides at the end to discuss the limitation of the study and one other recent trial with some discrepancies. My links of interest are not directly related to the topic of this paper, even if they are in the field of respiratory disease, but not about corticosteroids.
I'm sorry. So my links of interest. Just a slide about mortality of severe community-acquired pneumonia, SCAP, in the ICU. This is a cohort study from Barcelona in Spain. And the principal results was that mortality at 1 month after admission for severe CAP was 31%. But it includes only mechanically ventilated patients, and in your ICU we don't have only mechanically ventilated patients. When you look at this other cohort study that was recently published by a team of Louisville in the USA, in Kentucky, large cohort study about more than 107 patients, mortality at 1 month was 27%, even if only a quarter of patients were mechanically ventilated. And if you look at the mortality in clinical trials, this is from the Captivate trial that was published 10 years ago, and it was a comparison of placebo and tissue factor pathway inhibitor. The study was neutral, but the overall mortality on 1 month, on day 28, was 18%. But in the most severe patients, I just have my in the most severe patient here with a pulmonary injury score more than 130, the mortality was 25%. So Mortality for severe CAP in the ICU is high, and as you know, community-acquired pneumonia is the leader of infectious disease in the ICU. So this is a health public problem. When we look at the literature, this was published in 2017, and to be honest, it was after the beginning of the trial. But this is, to my opinion, a high-quality meta-analysis, and the conclusion was, okay, we can suggest there is a benefit of corticosteroids in CAP in terms of survival, but only if we include studies with what they call unclear risk of bias, and sometimes studies with high risk of bias. But when the meta-analysis is restricted to study with low risk of bias, there was no significant difference in terms of survival. So there was really a need for a clinical trial. So recently, at the beginning of April of this year, the European Society of Respiratory Disease, Critical Care Medicine, Microbiology and Infectious Disease, and also a South American Society published guidelines about severe community-acquired pneumonia, and they suggested not using corticosteroids in general cases, and only to use corticosteroids when shock was present. And this is related to the literature about corticosteroids in sepsis and septic shock. Surprisingly, to my opinion, they recommend methylprednisolone. I disagree with this recommendation because the high level of evidence in sepsis and septic shock is not for methylprednisolone, but for hydrocortisone associated with fludrocortisone. But this is not directly our problem today. So until recently, April 2023, it was published just before the electronic publication of the Cape Cod study, so it was not included in the guidelines. But there was a recommendation not using steroids in community-acquired pneumonia, even if severe form of CAP. So the Cape Cod study, Cape Cod is an acronym for community-acquired pneumonia evaluation of corticosteroids. It was funded by the French Ministry of Health, and it was conducted in 31 centers of intensive care medicine in France from all areas, and most of them belonging to the CRIX Trigger-CEP network. It's a network dedicated to intensive care trials and sepsis trial that was labeled by EFCRIN, the French part of the ECRIN, European Clinical Research Investigation Initiative Network. So basically it was a very simple design, but I have just focused on several points. The first point is we used for inclusion not only that the patient was admitted to the ICU with a community-acquired pneumonia, but we added severity inclusion criteria, and we defined 4 types of criteria. The first one, of course, was that the patient was mechanically ventilated with a positive inspiratory pressure of more than 5 centimeters of water. It was just to not to include patient chronically ventilated. The second criterion was to receive oxygenotherapy with high flow nasal cannula that appeared in our ICUs at the beginning of the study with a PaO2 and FiO2 ratio less than 300. It's a very useful parameter, very used parameter in ICU practice. We also admitted patients with oxygenotherapy via a non-rebreathing mask with an estimated PF ratio of less than 300, estimated because we can't measure FiO2 with this system. And finally, we also accepted patients with a pulmonary injury score more than 130, that is the group 5 in the classification of fine, and it's associated with mortality of 29% in the PREMSET study. So it's considered as a good estimation of the prognosis of CAP. So we included 44 patients mechanically ventilated, half of them with invasive mechanical ventilation and the other half with non-invasive ventilation. 42 patients receive oxygen with high flow nasal cannula, 14 with a non-rebreathing mask, and a few amount of patients all receive were oxygenated with one of these 3 devices. But a few amount of patients were included about the pulmonary injury score, and probably they were breathing with non-rebreathing mask with difficulties to estimated PF ratio. But all patients had one of these 3 devices. The second point, very important point, the window for inclusion was only 24 hours between the first of this criterion and the first administration of the experimental treatment. And in reality, all patients were included. The median time of inclusion in the study was 12 hours after the admission to the ICU. So a very short delay, and we will discuss at the end of this presentation the importance of this factor. We also had non-inclusion criteria, just focused on the 3 most important. The first, we recommended to test for influenza because there are some indirect data that suggests that corticosteroids could increase mortality in influenza. Just one randomized control trial with very few patients and very difficulty to include this trial into meta-analysis. So all the literature is based on observational studies with probably an important bias because the most severe of the patients receive corticosteroids. So we need probably a high-quality randomized control trial in influenza, but at this time it is not recommended to use corticosteroids in influenza, and it was a non-inclusion criteria. The second one was septic shock. As you know, the American Thoracic Society considered that community-acquired pneumonia is severe when the patient needs mechanical ventilation or where there is a septic shock. But septic shock was another question to our opinion, because there's a lot of papers that was published about this topic, and we don't want to have a pollution factor on our study. So we excluded septic shock. And the third important non-inclusion criteria was do not intubate order, because intubation for patients not intubated at baseline was a secondary outcome. So we excluded those patients. The exclusion of septic shock patient and do not intubate order patient means that the most severe of patients were probably not included. And we have estimated, I have no slide about this, but we estimated the mortality in the control group to be 27%. And we calculated the number of patients to include on the basis of a relative decrease of mortality of 25%. That is, we thought we will have 27% of mortality in the control group and 20.5% in the placebo group. And this was very conservative when we looked at the available meta-analysis that were published at this time when we began the study, because the the effect of the corticosteroids was supposed to be more pronounced than this 25% reduction of relative mortality. And in fact, we observed a lower mortality. Perhaps we will discuss for this point a little after. So very simple design. The randomization was stratified of mechanical ventilation. Patients receive either hydrocortisone or placebos. Both were industrially prepared, so identical packages. So there was really a double-blind study. Another particularity of the trial, we administered 200 milligrams of hydrocortisone or an equal volume of saline, of placebo, during 4 days. And during the day 4, we looked on the improvement or not of the patient about pre-specified criteria. For patients who improved, we used a short treatment and we tapered hydrocortisone for a total of 8 days. Isn't the same with placebo. And for patients we did not improve, we prolonged the treatment at full dose until day 7, and then we tapered progressively until day 14. I'm okay that the fact that tapering the dose progressively is not has not a high level of evidence today, but it was a choice at the beginning of the study. And importantly, we interrupt the treatment when the patient left the ICU. So the median duration of administration of hydrocortisone was 5 days. Please remember this point. We will discuss it again a few slides ago. So the flow chart, the first interim analysis about the inclusion of 400 patients, and then the COVID-19 pandemics arrive, and we have to interrupt the recruitment because all our ICUs were full with COVID-19 patients. We have used the same design and the same experimental treatment for testing them in COVID-19. We have published. Unfortunately, we have chosen another outcome. It was a composite of mortality and being mechanically ventilated in the ICU at 21 days, and there was clearly a tendency for better outcome for patients receiving hydrocortisone, but it was insignificant at day 21. At day 28, if we looked at the same criteria, there is a difference, a benefit of in terms of survival for hydrocortisone in COVID-19 patients. So we have the second interim analysis that was planned, but all ICUs were busy because of the pandemics. We don't have time to respond to the queries, and so the second interim analysis was postponed. And when the Data Safety and Monitoring Board at the results of the second analysis, they suggested to interrupt the recruitment. And so I will present you the 800 patients that were analyzed. Two important points. First, there was no patient with COVID-19 included in the Cape Cod trial. Both trial, Cape Cod and Cape COVID, there's no overlap.
We can't hear you anymore. Pierre-François? Sorry?
Okay?
Okay, now it's okay.
Okay, you hear me again?
Yes, yes.
Yes, and you have the slides. Okay, perfect. So, because to my opinion, patient with septic shock need to receive hydrocortisone with fludrocortisone. So there was not included in the study because we don't want to have results not interpretable. But I really think that our population is representative of patients admitted in the ICU for infectious community-acquired pneumonia. For example, little less than 600 patients were not included because they had inhalation pneumonia. Inhalation pneumonia is a chemical insult, not a microbiological insult, so it's very different. So just to focus on documented pathogens, we just recommended to the different centers to search for flu, for influenza, and to use usual test. So we don't have exhaustive documentation. Probably this explains that we have identified essentially bacteria and relatively few viruses. We have 54% of patients with at least one germ that was identified. This is a high proportion when compared to other studies. And of course, that means that 46 patients, the dark blue here on the diagram, we don't have pathogen. Probably for a few patients, they have infectious caps, something that mimics a cap. And probably for the majority, they had viral pneumonia due to different viruses, not influenza, but other viruses. So the principal outcome was mortality on day 28, and probably you know this result, but it was of 11.9% in the placebo group and 6.2% in the hydrocortisone group, and this difference was highly significant. Just to comment, we have calculated the number of patients to include about a basis of 27.
Again, we lost you. Hello?
Okay.
Yeah, we lost you for a while.
Sorry.
Okay.
I'm here again. It's okay?
Okay, now it's okay.
Sorry.
Maybe you can switch off the camera.
Yes, to comment this slide. Okay, so strange difference in terms of mortality, but mortality in the placebo group that was lower than predicted, 11.9 as compared to 27. I think I have underestimated the fact that in community-acquired pneumonia, patient died from sepsis shock, and perhaps in ICU died from withdrawing of therapeutic support for ethical reason. Or we don't include patients with septic shock, and we don't include patients with do not resuscitate order. So probably this is the explanation. I will briefly speak about the escape trial at the end, and they have the same observation. The mortality in the patient was lower than estimated. So look at secondary outcomes. So the death from any cause on day 90 was also higher in the placebo group, and it was significant. The p-value are into brackets because, to be honest, we did not adjust for multiple comparison. So, but clearly, when you look at the confidence interval, there is a difference in terms of mortality at day 90, and the proportion of patients that were alive and outside of the ICU was also higher for the patient receiving hydrocortisone. Important thing when you look at the cumulative incidence of intubation in patients not mechanically ventilated at baseline, and you can remember it was a stratification criterion. This is also a significant difference. Patients who received placebo had a higher proportion of intubated, 18 patients intubated in the hydrocortisone group and little less than 30% in the placebo group. The same is true for patients not invasively ventilated at baseline. The same is true for patients not receiving a vasopressor at baseline. We don't include patients with septic shock, but we accepted patients who receive norepinephrine for the correction of hypotension induced by mechanical ventilation with high PEEP level and with sedative agents. And so a few amount of patients received vasopressor at baseline, and I think it was 11%. But most of the patients did not. And the proportion of patients treated with hydrocortisone and secondary needing vasopressor was significantly lower than for patients who received placebo. Rapidly effect on organ failure, we did not observe effect on the PaO2 and the FiO2 ratio, which improved in both groups. But we looked at the SOFA score, which is a score of multiple organ failure. The decrease of organ failure was more pronounced and sooner in the hydrocortisone group, and this was significant. Okay, what with safety? It is dangerous to administer corticosteroid in patients who are infected. In terms of hospital-acquired infection, for example, we have to be prudent because the trial was not powered to detect safety signal. But when we looked, we don't observe more infection, secondary infection in the hydrocortisone group. In fact, they are a little less frequent in the hydrocortisone group than in the placebo group, but this is not significant. And the same result is observed when we focused on ventilator-associated pneumonia. It's a high incidence of ventilator-acquired pneumonia, but the same in both groups. Few patients underwent gastrointestinal bleeding. I'm not sure we have to look at this point now because the incidence is very, very low, but it was the same in placebo and the hydrocortisone group. And we observed higher incidence of hyperglycemia in the hydrocortisone group. This is a pharmacodynamic effect of corticosteroids. And the criterion we used was the amount of insulin that was administered to the patient during the first week and each day, and it was significantly higher in the hydrocortisone group than in the placebo group. So we have two recent trials. The ESCAPE trial, that was an American trial in the Veteran Hospital Administration, and the Cape Cod trial. The proportion of patients mechanically ventilated was not so different in both trials. The proportion of patients with vasopressor at baseline was not so different. The proportion of patients with high score of the pulmonary injury score was the same. The sex ratio was very different because this was a study in the veteran administration, so very few women, 3.6% of women. In the Cape Cod trial, it was 30.6% of trial. In any cohort of severe CAPS, the proportion of women is a third of the total population. So, and the age of patient was not different. But when you look at the results, in the ESCAPE trial, the main outcome was death on day 60, and there was no difference between the patient receiving corticoids and placebo. And we looked at mortality on day 28, and as say above, it was highly significant, and the same was true for mortality on day 90. So what was different between these two trials? The first, we have speak about the difference in sex ratio with very few women in the ESCAPE trial. The second, the steroid was not the same. The equivalent dose was the same in terms of glucocorticoid activities. That doesn't mean that the action of the cytosolic receptor for corticosteroid is exactly the same, but the glucocorticoid power was the same, but the mineralocorticoid was twice with hydrocortisone than with methylprednisolone. I don't know if this is the explanation. The inclusion window was different. I have insisted on this point, but we use a window of less than 24 hours post first severity criterion, and the American trial, they can include patients during the 4 days after hospital admission. And the treatment course was not the same. They administered methylprednisolone for 20 days, even if the patient was outside of the ICU, considering that the inflammatory process is longer in severe CAP and will require a longer administration of methylprednisolone. We use a shorter administration with a median time of 5 days, considering that when the patient was able to leave the ICU, there was no reason to administer corticosteroids and perhaps to expose him or her to side effects of steroids. And finally, there is perhaps heterogeneity in the treatment effect. For example, we have the repartition of the patient based on the C-reactive protein in the Cape Cod trial, but I don't have see it in the result of the ESCAPE trial, and you know it's perhaps a criteria of severity in terms of inflammatory process. We have conducted subgroup analysis, but please note that none of this comparison is significant in terms of interaction. So it's just explorative. We can conclude about this figure, but the results are some interesting. Perhaps the benefit is higher in patients not mechanically ventilated. In patients without isolated germ, I mean probably patient with viral infection. In the older patient, more than 65 years, in women and not in men. And please remember that one difference between the two trials was we included more women in Cape Cod trial. For patients with pulmonary injury score not too severe, and for patient with a CRP more than 15 milligram per deciliter. But I insist on this point, none of this interaction was significant. So this is just to have some hypothesis, but no more. So conclusion, in patient admitted to ICU with severe CAP, low dose, early and short course of intravenous hydrocortisone and not other corticosteroids. We don't have a class effect to date. Increased survival to day 28, decreased rates of intubation and vasopressor initiation, and appears to be well tolerated. So we have proposed this algorithm of treatment. First, it's applied in the ICU because those are severe patients, even if they breathe spontaneously, but with high flow of oxygen. So they can be worse in a few hours. The second point is we have to control the glycemia, the hyperglycemia, and it's easier in the context of intensive care unit. We have to exclude patients with influenza, although it's not very frequent in our practice, but for low-income countries, it must be important to exclude tuberculosis. We have a few amount of patients who were immunocompromised, so we can't recommend to use steroids in this patient, even if we remember that the first demonstration of the interest of steroids in pneumonia was for patients with HIV and pneumocystis jirovecii pneumonia. For patients with septic shock, we didn't study them in this study, but there are general recommendations for using steroids in this patient, and to my opinion, it's hydrocortisone with fludrocortisone. And for patients with CAP, with mechanically ventilated or receiving oxygen therapy with a PF ratio of less than 300, we recommend to use hydrocortisone. I'm sorry to have been perhaps a little long, and I thank you very much for your attention.
Thanks so much, Pierre-François. It was very interesting, and your presentation was really clear and very, very intriguing. So I open the microphone for any questions from the audience. But I start asking you a few questions because I think you did a very good job, and it is very interesting that all the primary and secondary outcome was in very coherent with the mortality result, but perhaps the PaO2-VO2 ratio, in which there was no such an improvement that one could expect from all the others parameters that improve. Do you have any hypothesis why you didn't see a real and clear-cut improvement in PaO2-VO2 ratio in your patients?
No. As you know, probably the first, there was another trial that has shown an improvement of survival with hydrocortisone. It was a study by Marco Confalonieri in Italy, yeah. And it was a preliminary study with the primary outcome was the evolution of PF ratio and the evolution of a score of organ failure. And his study was positive on those two criteria and also positive for survival. But there were there was 46 patients in this study, so not so much, and he observed zero mortality in the hydrocortisone group, and this was a little bit surprising. So that's why this study doesn't change the practice. But to respond to your question, the PF ratio increased in this study from a spectacular mean. I don't have explanation. I was surprised from this point. The other comment, we decrease the SOFA score of organ failure without improving the PF ratio. Or PF ratio is one component of the SOFA score. SOFA score is based on 6 organ failure, and the respiratory failure is based on the PF ratio and also using or not of mechanical ventilation. As our patients were not in septic shock, so there are relatively few other organ failure, few renal failure, and relatively few patients under vasopressors. Probably the difference is that there are few patients that receive vasopressor in the hydrocortisone group. That's why the SOFA score decrease, even if there was no difference in PF ratio. But I have no explication. I was very surprised of this. Yeah, at the beginning, my hope was to show improvement in PF ratio. I was not sure to show something about mortality. So, okay. I don't have explanation, to be honest. Yeah.
In your presentation, you stressed the short course of hydrocortisone compared to the other trials. And do you think that continuing the corticosteroid therapy too long can have more harm than can be more harmful than
Well, I'm not sure. Don't want to be descriptive because we have a meta-analysis of patients with ARDS. It's a little bit different from CAP, but the higher proportion of ARDS is based on CAP, and most of patients admitted to the ICU for CAP as the criteria for ARDS. If we accept to include patients who receive high flow oxygen with high flow nasal cannula, today this is not in the definition of ARDS, but it will change sooner, I think. So in ARDS are some data that suggests that there is no benefit when you use less than 7 days of steroids, and the benefit appears when you use more than 7 days of steroids. So, okay, I've seen the mean duration of administration was 5 days, but some patients receive, of course, more than 5 days. And today, my recommendation is to use 4 days of full dose administration to taper if patient improve, to continue at full dose for 3 additional days when the patient did not improve, and then to taper. And the total duration of treatment, to my opinion, and according to the data of the trial, is 10 days, not more than 10 days. I'm not sure that having 11 or 12 days is not safe, because the safety of hydrocortisone is good in anti-CFK. It was a lot of data with use in sepsis and septic shock. There is some concern about the possibility of myopathy, but there is no study shown an increase of hospital-acquired infection. Okay, there are some hyperglycemia, but it's not very difficult to control. So I think the tolerance is good. But I don't think we have to administer corticosteroid when the patient leaves the ICU. It's complicated. I think this is probably a lung cytokinic storm, not a general cytokinic storm, that is sepsis and septic shock, but a lung cytokine storm. We have to act early, but probably for a short period, and 7 or 10 days, not more.
Yeah. Another intriguing result is that it seems that from your trial, the patient who most benefit this therapy was those less severe, which is in some way counterintuitive. Or we already have the indication of using corticosteroid in septic shock patients, and you correctly excluded them. But from your study, it seems that with your regimen, the less severe seem those that most benefit from the treatment. And this is intriguing. And I would like to know if you have any hypothesis or idea about that. And this is also important for the following question I would like to know.
As you know, we have a lot of trials in the critical care settings that failed to prove an improvement in survival.
Yeah.
And there are several reasons, but perhaps one reason is that for critical care physician, it's important to decrease mortality for the most severe patient. It's logical, but perhaps this is not a good target. And because mortality in a patient with very high risk of mortality is sometimes difficult to decrease, and probably it's multifactorial. There are several parameters that explain this mortality. So perhaps a good target is a patient with lower mortality. The second point, okay, in the placebo group who has 11.9% of mortalities, it's less than the 27th we have project. But looked, what is the mortality of acute myocardial infarction? What is the mortality of pulmonary embolism? That are very strong interventions, or colleagues from cardiology learn to the students, this is very severe, this is okay. The mortality is largely less than 5%. So 11.9% is a higher mortality, is a high mortality, but not the most severe. I have some comment. I'm writing a position paper on this topic, and I have some comment for one of the reviewers. Okay, but it's not the most severe patients. So why? I think the reason is those are severe patients, not the most severe. It's probably more difficult to show something for very severe patients. And remember that septic shock patients were not included, and but it's difficult to the place of corticosteroids in septic shock patients remains debated. But there are some strong arguments to recommend hydrocortisone plus fludrocortisone in this patient, and it will decrease also the mortality from probably from a less extent than in less severe CAP.
Yeah. You mentioned different hypotheses for your results. The drug, which was a little bit different from the other cortisoid that were used, the sex, so female to male ratio, the severity, the short course, all are very interesting and reasonable. You finally find a spectacular efficacy, 47% mortality reduction against the 25 hypothesized. Do you think that there is a special reason for this, or it's a combination of all the factors you mentioned that bring so different results from expected and from all the other research projects that were published? What do you think is the main reason for this difference? This is to reason about the differentiation.
To be honest, I don't know. Perhaps we were lucky and we used a combination of factors that was operative, but well, we have to pull the results of all studies about steroids in CAP and steroids in septic shock from pulmonary origin to look at several points. The first point is that it's not usual to separate men and women in analysis, and perhaps it's a mistake. When you use steroids, it's related to the gender of patients. There are few data on this point. There is a post-hoc analysis of one of the big trials about cortisone in septic shock, the trial from the ANZIX group in Australia and New Zealand, and they suggested that in some secondary endpoints, the benefit was for men and not women. So it's quite different. So I think we don't know anything about this point, but it's very important to investigate it. The second point, perhaps, is the level of inflammatory process. The CRP value is important to consider. We have some discussion with a team in Rotterdam that use artificial intelligence to look at the results of several trials, and one of the preliminary results is that the importance of CRP in this topic, and we will look at if it's true only for the Cape Cod and Escape patients. The third point, there are some studies, two studies are with a positive result, and both use hydrocortisone. I think it's a very important question. I'm not sure this is what we call a class effect, that all corticosteroids are equivalent. But when you looked at pharmacodynamic properties, it's very difficult to show significant difference between glucocorticoid effects of different corticosteroids. So I don't know, to be honest. But we have to work about this point.
Yeah, sure. Any question from the audience? If you have any question, please raise your hand so we can give you the microphone. Considering the severity of these patients, the very short time to start, you were really very good in starting so rapidly, so early the treatment. And with this in mind, do you think that your result can be applied to emergency department practice. So do you think that people in the emergency department could or should consider hydrocortisone in those patients? Or because in your presentation, you underlined that those patients were in the ICU, but looking at the description of the patient, those are patients who are generally treated initially in the emergency room. So do you think that this can apply, and with what kind of indication?
Well, as a critical care physician, I will suggest to transfer the patient in the ICU rapidly, quickly, because sometimes emergency departments are very busy with a lot of patients with different severities. It's not an easy job, I think. So probably the easier way is to transfer the patient quickly. In some cases, for example, the small ICU with no bed available during a long time, it could be discussed, I think, between the emergency physician and the critical care physician. And sometimes it could be helpful to introduce the treatment in the emergency room. It's not complicated. It's a very easy treatment. Yeah. So it's not impossible, but. Just after, at one time, you have to transfer the patient because he will develop more often hyperglycemia, so he will use insulin therapy sometimes with continuous infusion. He will need a lot of support treatment. So it will be dangerous to consider that a patient could be treated with this approach in general ward, or to be treated all his stay in emergency room. I think it will be sometimes dangerous. But as a collaboration between emergency department and intensive care unit to begin the treatment before the transfer will be possible, of course.
What is your next study? What are you thinking about?
I'm sorry, I did not hear.
What is your next study? What next now?
Oh. Okay, we have we have collected some samples from biological samples in the blood of patients. It's very difficult to work about lung samples. In the research lab, we use also respiratory samples, but not for such a high cohort. So we have to work about these samples. We have samples at baseline, day 3 and day 7. For almost half of the patient included. So we have to work with these samples. I just discussed this morning about I will try to contact again the centers and patients to obtain data about their cardiovascular morbidity at distance, because the first patient was included at the end of October 2015, and the last one at the beginning of March 2020 because of the COVID pandemic, as I explained. So we have a long time since the inclusion of patients, and I think we are able to obtain some interesting data about cardiovascular morbidities. We know that patients with CAP are exposed to more cardiovascular morbidities than patients without CAP, and in the long term, but we don't know if the treatment at the acute phase is susceptible to decrease the incidence of this cardiovascular morbidity. And finally, to be brief, I have one other trial that I hope it will begin at the autumn. We will compare an administration of steroids and beta-2 agonist, but with nebulization in patients not mechanically ventilated, patient receiving oxygen therapy with high flow nasal cannula. So not the most severe, with the same reflection as we discussed a few minutes ago. We have some data that beta-2 agonists have interesting physiological effect on inflammatory process, not only bronchodilatory, but on inflammatory process, on the resorption of the alveolar fluids. and they have been tried in ARDS patients, but with negative results. Safety signal when beta-2 agonists are administered by the intravenous route, and no efficacy when they are administered with nebulization route. But I think it's not the good target, because the overall prognostic of patients with ARDS who are mechanically ventilated is it's quite complicated, and it's difficult to imagine that a specific drug could improve significantly the prognosis. But for patients in a less severe form of acute respiratory failure, perhaps we can decrease the rate of intubation. And as we don't include patients with do not resuscitate orders, for a patient not to being intubated is probably not to be exposed to death, because patients who died in the ICU are mechanically ventilated before their death. So we will try to show this result. What is more complicated, that we have to stratify about the systemic use of corticosteroids, because we knew that steroids are interesting in COVID-19. And we now knew that they are interested. Know that they are now interested in community-acquired pneumonia, most causes of most etiologies of acute respiratory failure.
Thanks so much.
It will be a necessity trial.
Thank you very much for having been with us, and for the clarity of and congratulations.
Thanks. Grazie mille.
Yeah, it was really interesting to hear you, and so we will wait for new study from your group, and thanks so much for being with us.
Thank you very much. Ciao a tutti.
Ciao.